Hello everyone, this is Brainless Medico and I am Dr. Manoj, and today we are going to learn one more important topic under hematology, aplastic anemia. So let's dig into it. Definition goes like this. It is a bone marrow failure disorder characterized by pancytopenia in peripheral blood and hypocellular bone marrow due to failure of hematopoietic stem cells. Yeah, it is a lengthy definition, but it covers almost all that subtopics which you need to learn under. So when it comes to etiology, we are going to see in two main different types. It may be acquired or inherited. So in acquired, we have most commonly idiopathic. So in etiology, acquired is the most common. In that most common cause in acquired is idiopathic. Okay, it's clear, right? Then drugs, some drugs causes like chloramphenicol, chemotherapy or anti-epileptics. Then chemicals like benzene, radiation exposures. Then viral infections like hepatitis virus, Epstein-Barr virus, and even HIV may cause. Then coming to autoimmune causes, there are some autoimmune causes which you can just come through when you are seeing in my rheumatological section. Then in inherited, we have Fanconi's anemia. We'll cover it in great detail because it is also one of the important topic. Then dyskeratosis congenita. Just remember the name, nothing more. Then coming to pathophysiology, important part, just focus on what I am reading, then we'll see in the pictorial data. Pathophysiology, immune-mediated destruction of hematopoietic stem cells which leads to activation of cytotoxic T lymphocytes, which release inhibitory cytokines like interferon gamma and TNF-alpha, which leads to suppression and apoptosis of stem cells. So at last what you need to remember is cytotoxic T lymphocytes will release interferon gamma and TNF-alpha, which leads to suppression and apoptosis of stem cells. So here at the end there will be destruction of stem cells. Actual function will be lost of stem cells. So reduction in stem cell pool, failure of erythropoiesis, myelopoiesis and thrombopoiesis. Since stem cells produces everything which is related to blood, but it has been destructed. So what happens? Everything will be reduced. Bone marrow becomes hypocellular and fatty because there will be nothing left when it is destructed. So it becomes hypocellular and fatty, which leads to pancytopenia. Obviously, there is no erythropoiesis, myelopoiesis or thrombopoiesis. It leads to complete reduction in every component of blood. So it leads to pancytopenia with low retic count. So you can see in this diagram, destruction of stem cells in the body, which leads to decrease all cell lines, which leads to pancytopenia. As I said, increases colonial stimulating factors, leads to fail like bone marrow struggles, but at last it failed to compensate because there are no stem cells. Then coming to clinical features, due to anemia, we'll see common features like fatigue, weakness, pallor, dyspnea on exertion. Then coming to thrombocytopenia, obviously there is platelet reduction which leads to bleeding related disorders like petechiae will be seen, purpura, epistaxis, nose bleeding, gum bleedings and even menorrhagia. Then due to neutropenia, neutrophil reduction will leads to recurrent infections, fever, oral ulcers. Then important negative findings. This is important because when another take it a consideration of iron deficiency anemia, which has similar investigation findings, almost similar. There are minor changes, but what mainly you need to focus when it comes to clinical features is no splenomegaly, no lymphadenopathy. These two are important, but these are positive in iron deficiency anemia. If you have not watched iron deficiency anemia, you can go and watch my iron deficiency anemia. I have explained everything detailedly. Then coming to investigation, as I said, pancytopenia due to reduction or destruction of stem cells, everything will be gone. Then low reticulocyte count, it has been already covered in pathogenesis. Why? Then peripheral blood smear, you are going to see everything will be reduced. So RBC, WBC and platelet will be gone. No blast or abnormal cells will be seen because there was no production itself. Then bone marrow aspiration, you will see hypocellular marrow. As I said, there will be stem cell destruction, which leads to fatty infiltration. See, when you are going to see bone marrow biopsy, you can see there are fatty infiltrations, right? There are full lump. It looks like from far like lipoma, like something like that, right? Fatty. Okay. Then we have absence of fibrosis and malignant cells. Then coming to severity classification, important. So let's look at it superficially and try to practice it again after seeing once after this video. Try to grab a paper, just practice it. That's it. It's simple. So we have three mainly: non-severe, severe, and very severe. In what is a columns we need to write: bone marrow cellularity, platelet count, retic count, ANC. Why you need to remember these columns are like bone marrow cellularity will be seen in all three: severe, non-severe, very severe. But in platelet count, you are going to see in non-severe, but we don't consider this platelet count in non-severe because it doesn't matter for us, because non-severe is not that great effective. So we just look into severe and very severe. It is less than 20,000. Retic count less than 60,000 or more, less than 1% CRC. But main important difference, like you have noticed that severe and very severe has platelet and retic count common. So we need to differentiate between severe and very severe by checking ANC, where for severe it is like less than 500, but very severe it will be less than 200. Let me revise it quickly. We have three: non-severe, severe, and very severe. In columns we have bone marrow cellularity, platelet count, retic count, then we have ANC. Non-severe, when it comes to non-severe, bone marrow cellularity we will take into consideration because it will be less than 25%, and it is most common in, like it is common feature in all three classification. But when it comes to platelet count, non-severe will be removed. Only severe and very severe we will be checking. So platelet count will be less than 20, less than 60,000. So common sense is like when you want to differentiate between non-severe and severe, you have to take consideration of bone marrow cellularity. When you want to differentiate between severe and very severe, you have to take consideration into ANC. Okay, that's it. Simple. Then other two, just remember 20,000 and 60,000. That's it. Then coming to management, let's go with the supportive treatment and definitive treatment. In supportive treatment, you have to give packed cell transfusion, platelet transfusion, infection control, avoidance of offending drug. But in definitive treatment, you are going to give, obviously, stem cells are destructed, so you are going to transplant them. Then immunosuppressive therapy. After transplanting, you need to suppress the immune because again they'll get destructed since it has been triggered by immune system. Then anti-thymocyte globulin to like this is mainly like reducing the immune system. That's it. Then cyclosporin, it is one of the immunosuppressant. Then what are the complications you are going to see is like severe infection, life-threatening bleeding because thrombocytopenia leads to heavy bleeding. Then progression to myelodysplastic syndrome or leukemia. Then examples. After everything, in every video, I'll give examples because at last, if you're revising 2 hours before the exam, this is what you need to read. Aplastic anemia presents with pancytopenia and hypocellular marrow. Reticulocyte count is low, no splenomegaly. Why? Because it is a DD of iron deficiency anemia. Then most common are immune mediated. So I think it was easy, a very important topic. I tried to concise it like in a 1-page notes. Just try to make it in a 1 page so that you'll revise well before exams. Don't run here and there for bunch of notes, and after doing exam you won't remember anything and you lose everything. So make proper notes. If anyone are like lazy to make notes, you can use my Gmail just to contact me. I'll be sending the PDF. No worries. That's all for the video. Don't forget to subscribe. Thank you.